about treatment of basal cell carcinoma. And what I would like to do today, actually I divided this into talks. In the first part, I'm going to talk about the standard surgical management and touch base on most micrographic surgery, and just a little bit on the aggressive types of basal cell carcinoma. And I'm going to focus on the topical therapy as well as intralesional therapies that we use in the last talk, when I'm going to be I'm going to go over treatment for squamous cell carcinoma. So this is an outline of the basal cell carcinoma management. Excuse me. So we all know that most of the time, at least in superficial or even nodular basal cell carcinomas, we use destruction or simple surgical excision. A lot of cases these days, they benefit from the most micrographic surgery, and in some cases they'll benefit from radiation therapy or chemotherapy, and I'm going to go over that. So standard excision, we're all aware of it. It means removal en bloc of the lesion plus a defined margin, and that's sent for permanent processing. The specimen is sectioned vertically, it's like you slice a bread, and then it's placed on the paraffin block. So this way the depth of the invasion can be easily measured, and also the nerves or the vessels can be evaluated. So the advantages of the what we call wide local excision, it's not only the gold standard for establishing a diagnosis, but it does provide an accurate description of the tumor actually, and it can evaluate or allow for evaluation of perineural, intravascular, or intralymphatic spread, which is very important. And it does have limitations. Only less than 5% of the peripheral margin will be fully evaluated, and it does take time. It's about 12 hours to create a paraffin block. So how about the Mohs micrographic surgery, widely used these days? It started out with Dr. Frederick Mohs, and who was a medical student in the 1930s. And he's the one who authored a book about harvesting and processing skin tissue for microscopic examination. And the first treated patient was actually a patient with squamous cell carcinoma on the lip. And interestingly, he was a dermatologist who worked actually in the surgical department, and he basically was able to present us today with a very special technique, a unique technique that is widely used in patients with non-melanoma skin cancer. It's widely successful. Now it's a tissue sparing technique. That means you only remove what you need to. It does have it allows for evaluation of the peripheral margins, so that's a plus. And it is employed only for certain tumors that will display a continuous spread. Now it cannot be used in patients with nodal disease or metastatic disease for sure, but it is used in basal cell carcinomas, squamous cell carcinomas, without local regional spread, and it's as I said, it's widely used because the cure rate, it's about 97% for primary tumors and about 95% for recurrent tumors. So just briefly going over the technique all of us are aware of, it does allow the surgeon to provide, to be able to remove the skin that's it's of concern, and then provides an active evaluation of that particular skin lesion. The advantages, as I mentioned before, it does give you a good appreciation of the margins, and it's a tissue conservation technique. But unfortunately, it does fail in tumors that are non-contiguous, which means they're apart from each other. There are some limitations of frozen sections, and I'm not going to go into that. I'm not a pathologist. And very important, it cannot measure the depth of the invasion. So Here's a patient of ours where the big question was, is Mohs appropriate in this patient? He's a 46-year-old man with status post stem cell transplantation who developed an ulcerated plaque on the penile shaft. Biopsy showed a microinvasive squamous cell carcinoma, and clinically you can appreciate the ulcerated plaque with somewhat rolled border, but here it doesn't project very well. There is a lot of pink redness surrounding this ulcerated area. So the question was, should we refer this patient to Mohs surgery or not? He was referred to us by the urology service. Well, in such cases, the very first thing that was done was a standard excision, because again, the depth of the tumor is it's very, to evaluate the depth, which is very important. So the plaque was actually excised, and then Mohs surgery was performed to clear the margins, and unfortunately that failed. So this patient was sent back to urology for a wide local excision. So this is to show you that not always Mohs micrographic surgery is the standard of care in some cases. So one may want to consider a wide local excision or an en bloc excision. Number one, in patients with altered mental status, that's very important. And patients with aggressive tumors, where prognosis is it's bad, and of course the staging really depends on the full assessment of that particular lesion, and in particular the depth. Another case of ours. This is a gentleman, 48-year-old, with Bruch-Spiegler syndrome, which is a multiple tumor syndrome. Many of us know it presents with multiple sweat glands or adnexal gland tumors, and also hair follicle tumors, sclerodermas, cylindromas, trichodemomas, all those fancy names. But this one had a basal cell carcinoma, actually. I don't know if you can appreciate it here on the inner left eyebrow. And the question was, should we refer this patient to Mohs or not? And yes, the patient was referred to Mohs because that was the standard of care. Well, after the first Mohs stage, no basal cell carcinoma was fine, actually. Interestingly, desmoplastic trichoepithelioma was noted in the first stage. But this patient required additional staging, and this is when the basal cell carcinoma was found, actually. So a somewhat difficult case where one may want to consider taking additional sections if the patient's at high risk, or we may, when we suspect further spread of the tumor. So again, another patient with a subtle basal cell skin cancer on the ear. You can see it here on the conchal ball, actually, where again the question was whether to do Mohs surgery or not, and the answer was yes. But this brings me to discuss the appropriate use criteria for Mohs micrographic surgery. So this is where I'm leading at, because at least in the United States, this procedure increased 400% from 1995 till 2009. 1 out of 4 non-melanoma skin cancers in the United States are now treated with Mohs micrographic surgery. So the question is does everybody needs Mohs surgery? Well, there are no criteria, which they were actually pinned down by the American Academy of Dermatology, along with the American College of Mohs Surgery and the Society for Derm Surgery. And the indications for Mohs surgery are actually patients with poorly defined tumor margins. These are very, very important. Aggressive tumor on histology, and my colleague talked about that. Aggressive tumor growth, so rapidly growing non-melanoma skin cancers. Very important to take into consideration the patient's immune status. So an immunosuppressed patient will definitely need to go to Mohs. Young patients, younger than 40, patients with recurrent tumors or perineural invasions. So what are the markers for aggressive clinical behavior? So this is another patient of ours with a very large infiltrating basal cell skin cancer of the vertex, actually. So the aggressive, we consider aggressive clinical behavior, basal cell skin cancer that are large to begin with. They have a deep invasion, perineural invasion, and location on high-risk areas. So these are considered the nose, the ears, actually the edge of the face, if you are to divide the face into a letter. The sides of the face, as well as the central face, are high-risk areas. And again, immunosuppressed patients. Also, it's important to know that 2 to 5% of tumors will reappear after most micrographic surgery, again, due to the aggressive behavior of this disease to begin with. And in such patients, additional treatment is necessary, which oftentimes consists of radiation therapy, and some patients may need chemotherapy. So we do perform malignancy workup for patients with where there's concern for distant metastasis, or patients with high risk or with high risk tumors to begin with. This is a multidisciplinary, there's a multidisciplinary team that we work with, including internal medicine, oncologists, radiation oncologists, pathologists. And oftentimes these patients, they end up having a staging performed, either a PET CT or a PET alone, to evaluate for further spread. And since I'm not an oncologist, I'm not going to go over any chemotherapy options or radiation therapy. I just want to briefly mention there are treatments available. Standard chemotherapy for metastatic basal cell skin cancer includes platinum-based therapies, but as I talked before, the hedgehog inhibitors are they're quite successful and used more often. What kind of imaging do we do for these patients? As I said, staging, you always check for nodal involvement. CT scan is very good at that. For bone involvement, it's been reported patients with metastatic basal cell skin cancer, they have bone involvement, a plain film, or computer tomography. It's also important for lesions located on the external genitalia. An MRI is preferred. And you may also consider a baseline chest X-ray to look for any pulmonary spread. So oftentimes blood work is being performed in these patients with high risk, complete blood count, liver function tests, basic chemistry. How do we follow up these patients? It's every 2 to 3 months full skin check with lymph node basin check also. Depending on the status, depending on the primary tumor, the location, these patients may undergo imaging studies every 4 to 6 months. And as I mentioned before, very important is the multidisciplinary approach. These patients cannot be in the hands of a dermatologist only. So, just to summarize, I think we all know that the surgery is a treatment of choice for most of the basal cell skin cancers. And we dermatologists, we can perform all the therapeutic options for basal cell skin cancers, but not all. And local therapy, sometimes it's needed, either with usually with radiation therapy, but sometimes immune modulating agents can be used, and I'm going to go over this in my last talk. Again, for tumors that are more difficult to treat, or the ones that are recurrent, high risk, and in patients where saving normal skin is very important, most micrographic surgery should be considered and discussed with the patient. And with that, thank you very much. And